Hi guys, welcome back. We shall now be talking about multiple sclerosis, which is an autoimmune demyelinating disorder. Myelin is produced by oligodendrocytes, and the main target of this disease, the autoimmunity mainly attacks the MBP, that is myelin basic protein. Now, just to get into the very baseline data, first of all, we will have a look at myelin's advantage. That is, it provides a insulation over the axon. The axon has been represented in yellow, then is the myelin. And I have also shown the blood-brain barrier symbolically in purple. We are aware of the fact that saltatory conduction allows very fast conduction across the nerve fibers in the brain. The normal speed of conduction across axon is only 1 meter per second. But saltatory conduction is very fast, about 70 meters per second. So if the myelin part will be affected, the conduction across the nerve fibers in the brain will be significantly hampered, and that is one of the hallmark features of the disease, that demyelination occurs secondary to the damage to the myelin component. Now, why is it all happening? So, well, the reason for that is obviously autoimmunity, and the incidence of this disease is more common in women as compared to men. We have also found an environmental risk factor for this disease, that is vitamin D deficiency. It has been shown that this disease is more common in North America than northern part of Europe, Scotland, England, etc. They have shown that those countries where sunlight exposure is lesser, that is where the disease is more common as compared to Asia or India. Why that is very surprising is because traditionally speaking, vitamin D is related to bone health and related to rickets and osteomalacia. But we are studying, and that is what Harrison has said, that probably vitamin D also plays a role in immune modulation. Because vitamin D in these patients is found to be lesser, therefore we find that the immune system does not work properly and starts attacking self. So how does the immune system attack self? Well, one, it will affect the permeability of the blood-brain barrier. You are aware that the blood-brain barrier triple B is composed of the food processes of astrocytes, and behind that would be endothelial cells. Since the blood-brain barrier permeability in this condition is affected by the damage by the immune system, therefore the investigational choice for this condition is gadolinium enhanced MRI. That will help you identify increased uptake of contrast in those areas where it should not happen, because in our brain, like in normal person, if you give contrast, there would be no uptake of contrast in majority of the brain. But here, because the permeability is enhanced, the contrast uptake will start occurring. So MRI, gadolinium enhanced or contrast enhanced MRI, is the investigation or the imaging modality of choice for this condition. I've symbolically shown here a T cell which will be attacking this blood vessel wall, that is the endothelial cells, and on the surface of the T cell we have a cellular adhesion molecule or CAM that you study in pathology called as integrin. Why are we studying this is because there is a highly efficacious molecule that's available for treatment of this condition called as natalizumab. The main mechanism of action of natalizumab is, and I'm handling that here only, is that it will interfere with the binding of the T cell to the endothelial cell and thereby prevent the further damage that would be occurring in this case. Also, I've shown symbolically T cells getting access to inside and causing direct damage to the myelin by producing various cytokines. The name of the cytokine I can write is like tumor necrosis factor alpha, which is incriminated even or read by you in multiple disorders, including inflammatory bowel disease. Now, the cytokines will have a one particular target, and the area that is being damaged is myelin covering, and myelin basic protein is affected in this condition. So symbolically speaking, I have also shown here damage to myelin, and therefore I'm saying that the conduction speed would be substantially hampered in this patient. Another thing that happens in these patients is damage to even the axon. So I have symbolically shown axonal damage occurring in this condition also. There are two things that happen in multiple sclerosis due to the immune component. One is myelin damage and second is axonal damage. So if I'm saying demyelinating disorder, it's damage to myelin. But from pathology perspective, if they say that what is the main pathological determinant of the disease or progression of the disease, the main determinant of disease apart from demyelination is axonal damage in this condition. This is surprising because normally you either have demyelination or you have axonal damage. Here both are occurring together. So if you read the pathology of the disease, you will read both about the component of demyelination, axonal damage, and on a comparison basis, if you have to select between demyelination and axonal damage, then listen to my words very carefully, that In a pathology-based question on topic of multiple sclerosis, according to Harrison and even in your pathology books, axonal degeneration in this condition is pathologically more important a problem for these patients as compared to myelin damage. Obviously, myelin damage plays a role. No, I'm not disputing that. But axonal degeneration or axonal damage, the dying back axonopathy that you read for this condition, that plays a important role in pathogenesis or development of this disease. So on a comparison basis, though both are answers in the question, but if they ask you single best response, axonal degeneration followed by myelin damage is to be answered in the sequence, not the other way around. As the normal impression is, because it's demyelinating disorder, so I should answer demyelination. No, it is axonal damage that is more important as a feature of the disease as compared to myelin damage. Now, once this has occurred, we have also found another interesting thing in this disorder, which is that the B cells will start producing antibodies in this condition, which will start again causing problems. The highlight of B cells causing damage is that these B cells have not come from bloodstream. They are the endogenous security system of the brain, like security system is present in the brain. So B cells of the brain are producing antibodies against a target. Now, what is the target? That's the second one to be remembered, apart from damage to myelin basic protein, is damage to MOG. I have told you that myelin, and you know also that myelin is produced by oligodendrocytes. Oligodendrocytes help in production of insulation around the axon, which helps in fast conduction. The antibodies start attacking myelin oligodendrocyte MOG, that is called as myelin oligodendrocyte glycoprotein. And once that happens, the repair system will now be kick-started into action. The name is MOG. I'll just write the full form here. That is myelin oligodendrocyte glycoprotein. That's the second target that is being impacted in these patients. Now, once the damage is done by both the B cells as well as the T cells in this condition, then the repair will start occurring in this condition. The body will try to, human body has huge powers of healing itself. When repair will occur, it's not that new neuron will be formed and new axon would be formed, because the damage is fairly substantial. So all that will happen in this condition will be fibrosis, and in CNS we don't use the word fibrosis, we use the word gliosis. Once gliosis occurs in this condition, this would result in formation of plaques, and these plaques are visualized by MRI, and in fact these plaques are mainly present in white matter area. This disease that we're studying today, the autoimmune disorder of the central nervous system, is a pure white matter disease. When white matter and gray matter are adjacent to each other. No, if white matter is damaged, then obviously gray matter will also be impacted, but it's a pure white matter disorder. So the plaques in this condition will mainly be seen in white matter area, like he will write in MCQ, gadolinium enhanced MRI. Remember I told you the imaging modality of this condition, gadolinium enhanced MRI, will be showing presence of periventricular plaques. Correlating this with radiology, the periventricular plaques, and I'll show you an image for the same also, is also called as Dawson fingers. So I have tried to link up the pathology with radiology component here, and two must-know facts at the moment for this autoimmune demyelinating disorder related to brain are: one, the investigational choice for this condition is gadolinium enhanced MRI, and the finding on gadolinium enhanced MRI is Dawson fingers. What are Dawson fingers? They're plaques. The plaques are formed as a repair to the damage which has been seen in the brain due to the insult by the autoimmunity. And this disease not only affects myelin but affects the axons also. The axonal conduction in this patient is affected. Most of the time it will be a patient who would be a young female and would be mostly residing in northern part of Europe or northern part of America, and might have come to you in India for medical tourism. You see, in India now medical tourism is increasing, so you might be getting patients from foreign. If they hear about you, they might decide to come and show you in India. So Delhi, Chennai, these are some cities where medical tourism is booming, or rather is increasing. So you would see a lot of patients, I would say foreign country patients coming to India because of cheaper medical care and good quality care being provided. So one of the highlights of this particular disease, and before I go into clinical features, I want to handle this, is that the neurological symptoms of this disease, they tend to be worsened or rather triggered on, let me say, doing any kind of physical exercise, or if person is having fever, then the neurological symptoms will start developing. Like for example, let me say optic nerve is involved in this condition by the plaques. So there would be problems with visual acuity of the patient. So this person will say that I cannot see clearly after taking a hot shower. Very surprising. I cannot see clearly after a hot shower. or let me say corticospinal pathways involved. So there would be spasticity causing cramps in the legs. Spasticity is increase or tone. For a non-medico does not know what is increased tone. They will say, I'm having cramps. So this young female, she's physically active. She goes for dancing, or she's joined some classes where she does some physical exercise. Like she's just joined a gym, she does running. She will come to you and say, after exercising, my cramps tend to increase. I'm not able to exercise. I've stopped going to the gym. I've started taking muscle relaxants. And even you as a doctor might think that, because of too much of exercise, she has developed muscle cramps. So lots of time initially, you will get this very particular history, neurological symptoms developing in these patients on heat exposure. Please appreciate the fact that I'm not teaching you heat intolerance. Heat intolerance is a feature of thyrotoxicosis, where the person feels hot all the time to increase in basal metabolic rate. Here I'm teaching the fact that the patient will complain or will develop neurological symptoms on heat exposure, which could be ranging from something as simple as taking a hot shower, or like in Western countries, steam bath, sauna bath, or for that matter of fact, having fever. The patient will say that my symptoms, which are multiple, visual complaints, spasticity in the legs, urinary incontinence, trigeminal neuralgia, because all the white matter system is involved in the patient. The neurological symptoms of these patients are triggered by heat exposure. Whenever body temperature or the core temperature of the body increases due to external factors, or due to, let me say, even fever, the neurological symptoms will develop. This was first explained in I would say 19th century by a Russian doctor in Russian females, where this disease in Russia is again a cold country where this was found. So what I'm teaching you, and is an important MCQ from medicine perspective, is called as Utov phenomenon. I'll just highlight what I mean by the word Utov phenomenon. It basically means that neurological symptoms in this disease are triggered by heat exposure. That's very peculiar, because you are not going to read about this anywhere else in medical literature except for this particular disease. So that's one very standard question that they've asked, that Utov phenomenon is a characteristic feature of, answer is the topic we're studying, multiple sclerosis. Now let's look at how the patient would present to us. So coming to the first clinical manifestation of this patient, and the question is very smartly designed on this. There would be two very close choices given: sensory symptoms and optic neuritis. Then Harrison says that 37% cases would be having sensory symptoms and 36% patients would be having optic neuritis. You might find it funny that I'm telling you figures here, but please appreciate they give very close choices. So sensory symptoms prevalence is higher as compared to optic neuritis. That is the message. What will be the sensory symptoms? They would be in the form of paresthesias, tingling sensations, or the patient might say that I feel as if somebody is poking me with a pin and needle over one arm, both arms, or over whole of the body, half side of the body. Why this is happening is because in this condition there is plaque formation with respect to the sensory pathways in the brain. So therefore, pin and needle sensation, paresthesias are the usual complaints of the patient. In fact, some of these patients might even tell you that there is a particular sensory level. Why? Because this disease can involve gradually spinal cord also. It's primarily involving the brain, can involve spinal cord also. So person might say that above a particular level, like patient might keep his hand like this at the level of the nipples, or maybe lower down at the level of the umbilicus, and say that below this line, I feel as if somebody is poking me with a pin or needle, or is tied a metal wire around my body and is tightening it. And above this, I'm totally fine. So a definitive sensory level. You will notice this kind of information of a definitive sensory level I have described in a topic called as transverse myelitis. So multiple sclerosis can rarely also involve or can involve spinal cord, and therefore sensory level will be described on the torso of the person, where above a particular level person will say I'm fine, below this I feel as if somebody has tied a metal wire, a military grade barbed wire on my body and is tightening it all the time. Then pain will always be a complaint of these patients, and this pain will be multifocal and will be of varying intensity. Like today this person is having severe pain in left hand, and the next day the pain might be in the right hand. So initially the first few consultations you might be wondering that is this patient ever having, is even having a neurological problem. You might think that the person is having some psychiatric reason. That's why this multifocal pain at different sites of varying intensity is being told to you by the patient. Normally person tells you, suppose somebody is having osteoarthritis of knees, then person will tell you knee pain only. Here it is like pain in the leg, then pain in the arm, then pain in maybe the shoulder. So it keeps on jumping from one area to another depending upon the plaque formation, and the plaques in these patients, they keep on developing over a period of time. That is why you read terms like dissemination over time, dissemination over space. So dissemination over space means that they could be developing in the periventricular area, then in the cerebellum. So the dissemination over space means at different areas of the brain, and time means that at different times. So symptoms in these patients will keep on waxing and waning. Like in any autoimmune disorder, symptoms will increase, symptoms will decrease. Similarly, in this disease, the same thing will happen. And now we come to a feature which is very characteristic of this disorder. And in fact, if they ask you what is the number one cranial nerve involved in multiple sclerosis, the answer is optic neuritis. The manifestations of this optic neuritis most of the time would be a decrease in the visual acuity of the person. This visual acuity reduction could be unilateral or can be bilateral, and mostly it is unilateral more than bilateral. So in one eye, person is not able to see properly, the visual acuity is lower, so person went to optometrist or to ophthalmologist, and he or she prescribed glasses. But then as more plaques will involve the optic nerve, the visual acuity will decrease even further. So person will again go to the ophthalmologist, he or she will change the glasses. So today you have a person who says, doctor, in last 6 months, I have got my glasses checked 3 times. Every time in one eye, my vision is becoming progressively lower. I have shown to ophthalmologist so many times. He has just told me change the glasses, but I thought that am I having some neurological reason for it? So person came to you just by chance. It can be incidental diagnosis. Another history that might be elicited would be change in the color perception of the patient, or I would say the patient will gradually might become colorblind. And this color blindness will not be uniform. Like this person might say that, doctor, I can see that you're wearing a blue shirt. But let me say over your right shoulder, I can see only in black and white. Like he can see the color of my shirt, he or she can see the color of my shirt. But over my right shoulder area, like there's one area where in the optic nerve, because there's a plaque related to that area of the vision, that circular area is where the color cannot be made out by the patient. He might say that this area, or person might point out to her dress she's wearing. She says that, okay, I'm wearing this pink dress or red dress, whatever. But in one particular area, I am not able to pick up the colors. So I'm not talking about scotoma, I'm not talking about a blind spot here, but I'm telling you that, yeah, the color perception in these patients in some areas could be significantly reduced. And that is what in pathology, or in rather ophthalmology, is referred as desaturation. Opthal desaturation basically means color perception is reduced in certain areas, especially in the central vision of the patient. There is no uveitis in this condition. If uveitis is present in a patient who's having this decrease of visual acuity, then the disease that you have to think in terms of could be neurosarcoidosis. In fact, that is what is clearly written in the textbook, that there should be no red eye in this condition. If it is uveitis present, then it is unlikely to be multiple sclerosis. Then you have to consider sarcoidosis, neurosarcoidosis as a presentation. The optic neuritis component can become so severe that this person can become blind, and this is one of the main reasons why we are studying this topic. I mean, young female going blind. This could be unilateral or it could be bilateral. Incidence of unilateral will be more than bilateral. There is a variant of this disease that is called as neuromyelitis optica, on which I've shot a separate lecture. So I also recommend you to go through the neuromyelitis optica component as well, where you would be having brain, spinal cord, and optic nerve all together. Look at the name, neuromyelitis optica. So there is a CNS manifestation. So there is a CNS manifestation, obviously, with transverse myelitis, with blindness developing in a patient. In neuromyelitis optica, there would be three manifestations occurring together. That is the CNS manifestations, like we're talking about, then sensory symptoms, for example, with spinal cord involvement, myelitis, sensory level, and then even optic nerve involvement can cause blindness in the patient. I've shot a separate lecture on the same, so I suggest you to go through it. And one of the hallmark features of this disease, or how do you pick this up in a MCQ, would be a question beginning with non-specific symptoms and then progressing to visual loss in a patient. You will anyway be doing a fundus in this patient because the patient is complaining of decreased visual acuity to the level of visual loss, and the fundus is usually normal. The reason for that is the problem is not in the retina of the patient. It is rather behind. It is retrobulbar involvement in this patient, that there are plaques in the optic nerve that are contributing to blindness in the patient. So most of the time the fundus will be normal, though he says sometimes evidence of papillitis can be noticed. If you go into the retrospective history of this patient, she will also tell you that for previous couple of months, I am having eye pain, and that eye pain is seen with movements of the eyes. So retrospective history, like initial complaint is that, okay, I cannot see properly, my visual acuity has decreased, and I've been to various ophthalmologists for getting my glasses checked. In the retrospective history, periorbital pain, which is increased on eye movements, can also be elicited in these patients. The next words that I say are very characteristic for this disease, especially from the perspective of solving questions in the exam, and that would be in the form of development of uh, damage to the medial longitudinal fasciculus. You see, you are aware of the fact that if you would move your eyes from left to right and right to left, both your eyes will move together. Like, for example, if I request you that, doctor, look on the left side, then lateral rectus on this particular side would help you to look towards left. But simultaneously, the medial rectus or the contralateral eye will also help you to move towards left, so that both of your eyes can move to left and then to right. So how is it possible that there is a coordination? The coordination is afforded by what is called as MLF, that is medial longitudinal fasciculus, and this area could be damaged by a plaque. Medial longitudinal fasciculus is where there's a cross connection, so that the lateral rectus of one eye and the medial rectus of the contralateral eye, they will both move together. Now, as I've shown here, a damage occurring here. So if there's a damage to the cross connection that is occurring or medial longitudinal fasciculus in the patient, then for a particular eye, like let me say on whichever side the damage is present, this is going to be supplying the medial rectus muscle. So there will be an impaired adduction. This eye will not be showing a adduction on one side. The eye can abduct, but adduction will not be possible. Contralateral eye movements will definitely be present. So let us now look at a question, an image base that was shown. Look at the central image. You will notice that in the first image, that is, I'm just putting a 1 here, the person is looking straight ahead and the eyes are just like any one of us. Then you have asked the patient to, let me say, look to the left side. So you will notice that both eyes of the patient can definitely move to the left side. That is lateral rectus of one eye, that is, and the medial rectus of the contralateral eye at the moment are being able to coordinate. However, when you're asking the patient to look towards the contralateral side, see what is happening, and I'll just zoom it in so that you can appreciate with the contralateral image. You will notice that one particular eye is not showing a adduction. You can see that this eye is moving laterally, no problems with that, but this particular eye is exhibiting what is called as a impaired adduction, and that is what I was highlighting, that in multiple sclerosis, because of damage to one-sided medial longitudinal fasciculus, the damage is occurring just after the crossing over, and there is a definitive impaired adduction on one particular side. Only one movement is getting affected, no impaired adduction. There is also another manifestation described in the textbook for this, that the normal eye might show a nystagmus. Why the normal eye might show a nystagmus is described as a compensatory mechanism. It's difficult to show nystagmus in a static image like this, but yeah, the normal eye might show a nystagmus to compensate for the deficit which is present on one eye. That is the Hering's law of equal innervation. That's what the textbook says, that Hering's law of equal innervation. If since one eye is showing an impaired adduction, the contralateral eye is trying to compensate for it. So the contralateral eye might show abduction or might show a nystagmus, which is not visible in this particular image. But the highlight of this disease is that because the damage is in the MLF medial longitudinal fasciculus, on one side there will be an impaired adduction. This manifestation, just to make it sound sophisticated, he's gonna use a terminology which is called as internuclear ophthalmoplegia. So I'll just jot it down the name here. INO, internuclear ophthalmoplegia, implies damage to the medial longitudinal fasciculus, which results in impaired adduction of one particular eye. The contralateral eye is able to move normally in the patient. Another manifestation that can be seen in these patients can be understood as follows. I'll first use two different colors to represent the lateral rectus activity. Lateral rectus is shown black, it will show abduction, and the red is showing medial rectus action, that is adduction. Now, my patient, I'll just use a different color to show the lesion. This person is having a plaque in sixth nerve nucleus, and function of sixth nerve nucleus is to cause abduction movement of the eye, lateral rectus activity. So I'm just putting a marking here to say that a person on whichever side the plaque will involve the sixth nerve nucleus or the adjoining parapontine reticular formation, there will be inability to look laterally. Also remember the fact that this sixth nerve nucleus is also connected to the contralateral third nerve nucleus and helps in adduction of the opposite eye. You can see in the diagram that the sixth nerve nucleus will cause lateral movement of this particular eye of the same side, but it also helps in adduction of the contralateral eye, so that movement will also be affected. Now I will show a second plaque. The second plaque is occurring in MLF, right? MLF is the crossing over again. I have shown right after crossing over a second lesion present, which is affecting the third nerve nucleus function, and therefore there is no movement of this particular eye. The impact is one eye is not moving at all, and in the other eye you can see only one movement is possible, that is the abduction component. Well, why? Because on the contralateral side the sixth nerve nucleus is not involved, so this manifestation is a simple straightforward manifestation called as 1.5 syndrome. Where is the lesion present in 1.5 syndrome? It would be on the side of 1 wherever there is sixth nerve nucleus, so it is sixth nerve nucleus on one side getting involved. Either he might write sixth nerve nucleus, or just to make it sound sophisticated, because sixth nerve nucleus is related to PPRF, that is parapontine reticular formation, so he might write PPRF also. But the bottom line is that whether PPRF sixth nerve nucleus is involved, the main manifestation would be that this particular eye, wherever the damage is present, that eye cannot look laterally, and the connection of the opposite side will also be hampered, because this has to feed the third nerve of the contralateral side, so there would be a impaired adduction on the contralateral side also. So one, there is a ipsilateral sixth nerve nucleus damage. Second, there is a ipsilateral medial longitudinal fasciculus lesion present. So there are two plaques that are present here. The plaques are present in sixth nerve nucleus / PPRF and same sided MLF, which results in one eye not being able to move at all, and second eye only the abduction component is possible. In fact, most of the time in MCQs what they will ask you for 1.5 syndrome will be what is possible. So what is possible is contralateral abduction, simple, straightforward. 1.5 syndrome, one eye is not moving at all, and in the other eye what is possible? Only abduction of the contralateral eye is possible, and lesion is present on one particular side, and there are two lesions present here, one on the sixth nerve nucleus of PPRF, second on the medial longitudinal fasciculus. So one of the main reasons why we are discussing this topic is to handle this neuro-ophthalmological component 1.5 syndrome, and the second feature of internuclear ophthalmoplegia. Internuclear ophthalmoplegia means the present damage is only on medial longitudinal fasciculus. So first I've explained what do I mean by the word ino, which means that MLF is gone, so therefore on one side there will be no adduction. Get the words right, only adduction component is gone because the damage is right after the crossing over. So impaired adduction is a feature of internuclear ophthalmoplegia. Just get the terms right. I'll repeat once again. I and O, internuclear ophthalmoplegia, whichever side the plaque is present or causing a damage after the crossing over, that is medial longitudinal fasciculus means tract which is communicating the left and the right eye. The damage is present right after the crossing over, so on that side there is a impaired adduction in the patient. On the other hand, when it comes to patients of 1.5 syndrome, then the only movement possible in the eye will be opposite eye abduction present. Then to trouble you, he can use terms like 8.5 syndrome. What you mean by the word 8.5 syndrome is that even seventh nerve nucleus can be involved by a plaque. So there would be three plaques. One plaque affecting sixth nerve nucleus in PPRF, one affecting same-sided medial longitudinal fasciculus, and another affecting the seventh nerve nucleus, because plaques will indiscriminately develop in multiple sclerosis. So seventh nerve involvement and 1.5 more, that would be 8.5 syndrome. So I mean, they just mention these terms, they look very hi-fi, but they're very straightforward manifestations of CNS lesions in the brain. The main impact or the main reason you have to study them is because in the exam when they start saying ipsilateral contralateral, things start going wayward. So you need to get a focused orientation for this topic, that in 1.5 syndrome only movement possible is contralateral eye abduction possible. Name is 1.5, so one eye is not moving and one eye the adduction component is not there. Abduction is very much there, as you can see in the diagram. And for internuclear ophthalmoplegia, the only thing that is affected in the patient is adduction, ADD, adduction in a patient. So what I'll do is I'll just go back in my slides and highlight these terminologies here, because most of the time in MCQs, they will like to ask you regarding one ino and second 1.5 syndrome for this particular case. I repeat once again, if seventh nerve nucleus is also involved in this patient, then 7 plus 1.5 will become 8.5 syndrome for these patients. Once you get this right, we go to the third manifestation of this patient. That would be a weakness. This weakness is usually increased on doing physical activity. You see, we all get tired at the end of the day. So what is the big deal about it? But here the patient is not talking about like the end of the day. The person is, let me say this is a housewife. She's saying that I get tired even on chopping vegetables. Like she loves to cook. This lady, she's a homemaker, she's a housewife, and she loves to cook. And she says that earlier I could do all the chores on my house, going up and down in the house I could do. Now even chopping vegetables is a task for me. I mean, chopping vegetables, you're cutting onions and tomatoes, maybe two onions, two tomatoes. That's like a routine, you cooking food for yourself. And for this lady, she says like even making food for two members in the family or food for myself is like a task for me. And earlier I used to love cooking, and I used to do extensive 2 dish 3 dish course on lunch and dinner, and now this person is getting tired very soon. Why that is happening is primarily because of the corticosmile pathway which is getting involved in this patient. So on physical examination, the person might say that I'm feeling cramps. Like when you are touching and doing a systemic general neurological examination, on examination or tone of the patient might say, oh, I am having cramps in my arm, I'm having cramp in my thigh. And that cramp is hypertonia, which is actually the spasticity component, but the person does not know obviously what is spasticity, that is hypertonia. So he or she might call it cramps. And if the person is physically active, like she is going up the stairs, she might develop hamstring cramps. She says like this has happened so many times. I've shown orthopedician, they're given muscle relaxants, but they keep on increasing. I would here also like to tell you that spasticity is like a blessing in disguise for these patients. Why blessing in disguise? Because the increased tone will help this person stand. You see, had the tone become lesser, person would not have been able to even stand. And in these patients, in the later part of the illness, there is a possibility that spasticity might be so severe, the stiffness might be so severe that person may not be able to walk normally. You will notice a abnormal gait, that the person is having difficulty in walking, but it will not be a normal gait in the patient. Upper motor neuron lesion findings will always be seen in these patients, like brisk DTR, Babinski sign. Do not be surprised if in this patient's spinal cord lesion, if the plaque develops in the spinal cord, then lower motor neuron manifestation may even be noticed in a patient. So don't be surprised that if he gives you an examination finding of this particular patient of spasticity in the right arm and fasciculations in the left arm, because fasciculation is lower motor neuron finding. So this disease can be having simultaneous occurrence of upper motor and lower motor manifestations in a single patient. That is very atypical, because normally we either have upper motor or we have lower motor. Single patient having both these manifestations, I have described even in a disease in the later part in the app. You would read about motor neuron disease. I have there described regarding Stephen Hawking. He used to have these manifestations of fasciculations in one hand and spasticity in the other hand. So now you're aware of two very classical disorders where you can have combo of upper motor and lower motor, that is amyotrophic lateral sclerosis or motor neuron disease, and the current topic of interest, that is multiple sclerosis. Then you could be having cranial nerve palsies in these patients in the form of facial nerve palsy. This facial nerve palsy, however, is different from the Bell's palsy that we normally study, because the damage is occurring to the nucleus of the seventh nerve in the pons. So there is a plaque in the pons of the patient causing seventh nerve damage in the patient. Highlight of this facial nerve palsy is that the taste sensation is preserved. So how do you differentiate this from Bell's palsy? Is that Bell's palsy, the taste sensation is also lost, but here taste sensation is preserved. The next manifestation that occurs in these patients is very classical, and that would be development of cerebellar involvement, that is ataxia. Due to this ataxia, now walking might become a difficulty to the level that person might fall, because cerebellar disease patients, they might be having a drunken person's gait. If they try to walk very fast, they might actually lose their balance also. Features might be written in the question like gait ataxia or limb ataxia. Gait ataxia occurs due to damage to a part of the cerebellum called as paleocerebellum. So this person will be having broad-based gait or drunken person's gait. You and me can sit in a chair comfortably whole day. Our truncal muscles are able to handle the stress of sitting in a chair and studying and listening to app lectures the whole day. Here truncal ataxia will occur in a patient. So person may have difficulty in sitting on a chair now. The part of the cerebellum where the plaques are causing damage is archicerebellum. So these are two again questions which are to be remembered. One Mnemonic that I can use, as a shortcut to make you remember is the word gait ataxia. Gait ataxia. GP is general practitioner. So G is gait ataxia and P stands for paleo-cerebellum. That will just reduce the load on your brain. But gait ataxia is due to plaques damaging paleo-cerebellum. Truncal ataxia due to damage to archicerebellum. So difficulty in sitting might be seen in this patient. Then cerebellar involvement in these patients can also cause scanning speech or statico speech. Meaning of the word scanning speech would be that person will be not able to speak fast like you and me. The person will say words very slowly. Like if I say medicine, he'll say M, E, D, I. So the speech will be very deliberate with effort and every word would be phonated separately. So scanning speech, or because you might lose your patience, patient is speaking very slowly. You may not actually understand what the patient is trying to say. So scanning speech is a feature of cerebellar lesions that would be encountered in these patients. Then vertigo and deafness may also be noticed, that is related to eighth nerve. In case the fifth nerve nucleus is involved, these patients can develop trigeminal neuralgia. Though trigeminal neuralgia can be present idiopathically also, but in these patients it could be bilateral, and the highlight would be like the patient might say that I feel as if somebody has cut my face with a piece of glass. Like this lady, she says that when I'm sitting in front of air conditioner and the cold air of the AC hits my cheek, then I feel as if somebody has cut my face with a piece of glass. Or she might say that somebody is like try to pull my skin away. So trigeminal neuralgia is a horribly painful condition. We might have to use carbamazepine for management of these patients, and in spite of carbamazepine, the symptoms in these patients might persist to a substantially large level. You might even have glossopharyngeal neuralgia in these patients, because of which there would be pain on even swallowing. So person might say that I feel as I'm drinking acid, or she might say that I feel as if I'm swallowing a piece of glass. So cranial nerve involvement is a feature of this condition, and out of which, as I've explained to you, that the involvement of the optic nerve is the early feature of the disease, or one of the classical features of the disease. The next features that are described in this patient are called as ancillary symptoms. These could be in the form of one patient saying that whenever I flex my neck, there is a shooting pain in my legs. We are talking about Lehermite sign. Neck flexion is causing shooting pain developing in the legs of the patient, or radicular pain in the legs of the patient. We read about this manifestation of Lehermite sign with respect to one Tapes dorsalis, and we also read about this with cervical spondylosis. So three causes of Lehermite sign we can remember are the topic of interest: multiple sclerosis, cervical spondylosis, and Lehermite sign in a patient. This would be a transient shooting pain in the legs of the patient that would be developing. Then another very specific feature which is written is twitching of the muscles of the face, that is facial myokemia. This would be fluttering of the eyelids or twitching of the eyelids. It could be upper eyelid, lower eyelid, twitching of the muscles. It's different from fasciculations in a sense that there would be only selective area that would be involved. It would be these flickering movements that can be perceived by the patient. In fact, this myokemia can occur in any one of us related to stress or when we are tired. But in this person, this would be a regular event of flickering movements of the muscles, which would be visible and can be perceived by the patient. These would be only for maybe few seconds to a few minutes, but they are developing very suddenly. The 10th manifestation of this patient would be bladder involvement. You see, the brain can control the bladder. I can put it like this, that if this is the detrusor muscle, this is the internal urinary sphincter, and then is the urethra. Then whenever detrusor muscle will contract, then the internal urinary sphincter should relax so that the urine can go forwards. So there has to be coordination between the contraction of the detrusor and the relaxation of the internal urinary sphincter, so that the urine that is present in the bladder can flow out into the urethra of the patient and a person can urinate properly. In this person, two possibilities can be there. Either there can be a detrusor hyperreflexia because of damage to the pathways, descending pathways which are controlling the bladder. One possibility is that the detrusor is contracting with more force than normal. Why? Because in any central nervous system lesion, there is loss of inhibitory control. So inhibitory control is lost, then the pathways will be conducting faster. So the detrusor will contract faster, and therefore in this person, there might be difficulty in controlling the urination. A normal person, you can control the speed of urination. Here, a person might have difficulty in controlling urination, and urine might be passed in the clothes also. Like he's feeling like he wants to go to the bathroom. But even before he will reach the bathroom, because of this detrusor hyperreflexia, the urine might pass out in the clothes of the patient. So, therefore, the personal hygiene of these patients gets compromised subsequently, and urinary incontinence can develop. Initially, it might even present in the form of nocturnal enuresis. I mean, the patient might say that, adult patient is saying, doctor, I don't know what is going on, but, adult female, she was sleeping comfortably and she passed urine in the bed and she's very embarrassed because of that. And this has happened a couple of times. And then this might happen even at daytime. The person is in college, office, and suddenly person felt like going to bathroom, and before the person could reach the bathroom. There are two reasons here. Person could not reach the bathroom on time because there is spasticity in the legs. Second, the bladder contracted faster, so there is a urinary incontinence developing in a patient. Another manifestation is detrusor and the sphincter coordination will not be there. So the word is detrusor sphincter dyssynergia. Now see what is happening. The detrusor is contracting, but sphincter is not relaxing. If the detrusor will contract and the bladder will not relax, then person will not be able to urinate. So what will it cause? Urine retention. So you will read both the things written, and that is why I usually get queries from a lot of students saying that, doctor, how is it possible? Either it should be incontinence or it should be retention. I am saying depending on the manifestations of the patient. If detrusor hyperreflexia alone is present, then you would be having a urinary incontinence because it will contract with force even person reaches the bathroom before that urine is passed. Detrusor sphincter dyssynergia, that means no coordination, so urinary retention could be present. Due to retention, there could be increased incidence of UTI, cystitis in the patient, suprapubic discomfort. So you will notice a lot of these patients, behaving in a very abnormal fashion and not being able to tell what is the problem with them. Why I'm saying behaving abnormally? Because put it on yourself, if you're having suprapubic pain and you can't tell it to a doctor, because when you are speaking, your voice is not very clear because your cerebellum is also involved, or your vocal cords are also involved because 10th nerve is getting involved, the plaques are involving the base of the brain. So due to lack of ability to communicate to a doctor, suprapubic, I mean pain or discomfort anywhere in genital area or private parts would obviously be something which will cause distress to anybody. And a person would like to tell that to a doctor so that he or she can get relief. And in these persons, even communication becomes gradually hampered, and physical mobility also becomes hampered. Physical mobility becoming hampered due to corticospinal damage, cerebellum damage. And look at the surprising thing that I'm saying here. You see, if I'm talking about stroke, stroke will affect one part of the brain only. This disease affects almost whole of the brain gradually. You see, the white matter part is everywhere. So corticospinal pathway, cerebellum, optic nerve, cranial nerves, they all start getting involved gradually in the patient. So there's a gradual deterioration of these patients. That is why to scale out the manifestations of these patients, we use a scaling pattern. This scaling pattern that we use is called as EDSS, that is Expanded Disability Severity Score. I'll just explain this out to you so that you can understand the treatment part relatively better. The word is EDSS, Expanded Disability Severity Score. In this, we rate the patient with respect to manifestations from 0 to 10. 10 would obviously mean death in the patient. So let us see, what do you mean by 9.5? EDSS score of 9.5 means that the patient is completely bedridden. Why? Because there is damage to cerebellum as well as corticospinal pathway. So person is bedridden. The person can't talk. Can't talk because there is bulbar palsy occurring in the patient. So vocal cords are not able to function, or cerebellar damage is so severe that person can't talk. And person can't even drink water. So you are having to put in a tube in the patient, or you might have to do a gastrostomy in the patient. So can't talk, can't drink, can't swallow food. I mean, if you put food in the mouth of the person, he might choke. That's the amount of disability. I will give 9 points to a person of multiple sclerosis who's completely bedridden, but at least can talk. At least can say that, okay, this is the problem that I'm having. At least he can drink water. How? At least with the help of a straw. Like he may not be able to swallow normally, like holding a glass in the hand and drinking water, but with the help of a straw, if assistant is holding a glass of water with a straw, person can generate little bit of force to drink water, and at least thankfully there is no aspiration that is occurring. On the other hand, if I go to the left hand side, 3.5 is a patient who is fully ambulatory. At least the person can go to the bathroom by walk to the washroom by himself. This person cannot go for morning run and jogging, etc., etc., but then fully ambulatory, at least daily personal hygiene, like person can go to bathroom, take care of personal hygiene, shave in the morning if it's a male patient. So I mean, basic things can be done in a patient. So we rate our patients of multiple sclerosis on the basis of each of the symptoms that I've explained, and there's a rating system for that. Now that rating system we don't need to get into, that's a big whole page in Harrison, and that's mainly for use of neurologists. But you have to understand the fact that we have to evaluate the patient's functional status, because only then we will treat the patient. And what I mean by treating is that I have to improve the quality of life of the patient. Like suppose a patient is having a score of 9, I know that I might lose the patient, so I have to be trying to prevent the development of a score of 9 by interfering at 3.5 only. And what will I do here is the concept of disease modifying drugs being used in the patient. You see, like in rheumatoid arthritis, we study about DMARDs, disease modifying anti-rheumatoid drugs. Here I'm talking about disease modifying drugs which will monitor the progression of the course of the disease. So what can I use to basically slow out the process? Here are various drugs that I'll discuss with you. But one of the drugs that we use initially for management of these patients is beta interferon. We give injections of beta interferon, which can be given intramuscularly once a week or subcutaneous thrice a week. We have once a month injections now gradually coming up. So beta interferon is a disease modifying treatment. Please appreciate that if he says acute manifestation, acute attack of multiple sclerosis, like he talks about just the fact that a young lady has suddenly gone blind. What will you do for the patient? If she's already gone blind, then beta interferon is not going to do anything, because it will prevent the development of manifestations. Acute attack, the drug of choice should always be answered as steroids, that is intravenous methylprednisolone for the patient. So do remember these minor aspects that I've highlighted before you. If the question talks about the acute attack of multiple sclerosis, it is methylprednisolone. Obviously you need to rule it out from a pseudo exacerbation. Like I said, after jogging, if possible in the early part of the disease, or taking a hot shower or steam bath, sauna bath, like in Western countries, person might start having not being able to see properly. That's a pseudo exacerbation, in a sense that is Uttha phenomenon. That's a feature of the disease. For that you don't need to give steroids. If you cool down the body, that the cold temperature comes down, the symptoms will gradually disappear. But if a person is having a blindness manifestation, acute attack of multiple sclerosis is causing blindness in a patient, then the drug of choice is methylprednisolone. And to prevent the further disability of the patient, there are multiple drugs that I have explained to you, but the first drug that we use is beta interferon, which is an immunomodulatory drug that will prevent the further progression of the disease in the patient. Let's now look at what are the investigations that would be done in this case to be sure about the diagnosis. I have rather talked about the treatment first, because I have explained the clinical profile of the patient. So it was my job here to explain to you that what are we going to do after all. I mean, why are we studying all this? Because we have to halt the progression. So more drugs will be discussed in the subsequent part of the discussion. But here I just wanted to tell you that our job is to identify the condition on basis of multi-centric white matter involvement in the patient. That is why we are saying dissemination over space and dissemination over time. That is, over a period of time the manifestations will start occurring in the patient. So let's look at the McDonald's criteria that are used for diagnosis of this condition. I'll explain to you revised McDonald's criteria, which are useful for identification of multiple sclerosis. The first and the foremost thing that he says is that the manifestations in these patients may not develop simultaneously. Like suppose symptom that developed was muscle cramps. The symptom will increase, then will stabilize for a few days, then will gradually even reduce subsequently. The symptom that developed in a young lady on the starting of, let me say, 2019 January, the symptom that developed was only in the form of spasticity, and what the person is not saying spasticity, person is saying muscle cramps, and they have gradually settled down. This was in the month of January 2019. Then February, March were okay, and let me say in the month of April 2019 a new symptom was developed. That is, for few days this lady, when she was sleeping, she passed urine in the bed. She was very embarrassed because of it. She did not tell anybody. But then since the symptoms were very, very persistent for 3-4 days, she came to you and told you that, doctor, this problem is occurring, and you started doing her workup. So when you are gonna do a charting of the symptoms of the patient, you will notice that the disease has a waxing and a waning course. That is, the symptoms will develop, then will stabilize, then will go down. So this time it was enuresis or it was urinary incontinence occurring in the patient. Then the month of May, June were fine, and in the month of July, then there was a new symptom developing in a patient in the form of difficulty in noticing the color of a dress in the central part of the vision. What I was talking about, desaturation, that she can see the color of the whole dress, but in the central part of the vision she says, I just can't see the color. So this time she is literally going color blind, or her visual acuity is also reducing simultaneously. So I'm not saying that she's gone blind, but her visual acuity has reduced, her color vision has reduced. So symptoms in these patients take their own sweet time to come. They remain there, then they tend to go down. So this is usually the common find of common presentation of multiple sclerosis, and we will call it a relapsing variety of multiple sclerosis. So relapsing MS, RMS, relapsing multiple sclerosis is the most common subtype of multiple sclerosis. However, let's look at another version of it. Suppose the patient says that in 2019 there were symptoms that were coming, going over, and you will notice all symptoms will not occur together. They will always be separated by weeks and months altogether. So you will notice that the symptoms were coming and going in 2019, but in 2020, the manifestations that have developed in the patient, they are now one symptom has come and then the second symptom has developed. So there is no improvement in the condition. Like person says that 2019 was good for me, at least that there were some asymptomatic periods in between. But now the symptoms are coming one after the other. So this presentation is called as SPMS. That is in 2020 January. The symptom January, February, March, no symptom is going away and the new symptom is coming up. This would be called as secondary progressive multiple sclerosis. SPMS. Secondary progressive multiple sclerosis can be identified only if you monitor the course of progression of the disease. However, in some patients, it might so happen that there might be no period of asymptomatic scenarios in between. It might be just one symptom after another and there is no improvement in the patient. So I'm going to call it primary progressive multiple sclerosis. This is relatively less common, only about 10% of cases. So MCQ wise, now he has classified multiple sclerosis into three varieties. That is relapsing multiple sclerosis, which is a standard feature for all autoimmune disorders, secondary progressive and primary progressive multiple sclerosis, with primary being least common and most severe. I mean, this is least common and most severe variety because there is no improvement or let up of the disease activity in between. Whereas relapsing remitting is what normally autoimmune disorders will progress as. So revised McDonald's criteria says this: you should be having at least two symptoms present in a patient. Each of these symptoms, like for example spasticity, for example decrease in visual acuity, color vision, the symptoms should be lasting for more than 24 hours. Why? Because I want to differentiate from TIA, transient ischemic attack, in a patient. So symptom duration, each symptom duration should be more than 24 hours. Both symptoms should not occur simultaneously, because if both symptoms are occurring together, then it could be stroke also. The symptoms should be separated by at least a time lag of 4 weeks, or it could be more than this. So I highlight the statement here that you should not misdiagnose stroke as multiple sclerosis, because stroke can also have cranial nerve involvement in a patient. Stroke can also have corticospinal pathway involvement in a patient. Here the symptoms are gonna be occurring one after the other, but would be separated by a gap of 4 weeks, and every duration of symptom should be more than 24 hours. Why? Because you need to differentiate from transient ischemic attack. Now, once these are present in a patient, you will do workup of the patient, that is gadolinium enhanced MRI. This is the preferred imaging modality of choice for this condition. In gadolinium enhanced MRI, you will be able to notice presence of plaques. These plaques would also be called as Dawson, DAWSON, Dawson fingers. Where would they be located? They would be in the white matter area. So how in the MCQ will he say white matter area? He will use the word periventricular. That's adjacent to the, outside the brain is gray matter, then white matter, then ventricle. So periventricular. Or you might say juxtacortical. That is junction of the gray matter and the white matter is juxtacortical. Then is cerebellum. How will you write cerebellum in the question? He will say inferior, or he will write infratentorial. You see, cerebellum is a little inferiorly located as compared to the rest of the cortex. So the word is infratentorial. So when you read terms saying periventricular, juxtacortical, infratentorial plaques present, and if the size of the plaques is more than 6 millimeter, then it is suggestive of diagnosis of multiple sclerosis. However, the problem can be that sometimes these plaques may be smaller and may not be visualized. I'll just show you an image for the plaques so that you can appreciate the disease relatively better. And in this image, in fact, I'll show you two of them. This is a FLAIR image. I'll highlight the meaning of the word FLAIR, that is fluid attenuated. That's again a question for you. FLAIR MRI, that is a fluid attenuated inversion recovery system. What you do in this system is fluid attenuated inversion recovery system. You basically suppress the signal of the CSF. And if you suppress the signal of the CSF, then the periventricular lesions will stand up relatively better. So you can see that here, this is the area of the corpus callosum. We are seeing a sagittal section. So we are here noticing that in the corpus callosum of the patient, which is a white matter area connecting the left and the right cerebral hemispheres, there are these whitish lesions present, which are Dawson fingers or plaques. So because they have this finger-like configuration, they're referred to as Dawson fingers. I'll show you one more image highlighting the same. In the subsequent image also, they are much more highlighted, in fact. The periventricular lesions are even more highlighted in this patient. So every time you get a MRI head in which you are noticing these periventricular lesions present, which are vertically aligned to the area of the ventricles, and ventricles are having CSF, signal would be black, and surrounding that would be horizontally aligned lesions which are white in color, hyper intense in majority of cases. So you will say that those are periventricular plaques of multiple sclerosis, and along with that, obviously, symptoms which are spread out by time and space would be described in the patient. Now the problem is that if the plaques are small, they may be missed. So we will have to now rely on what is called as VEP, that is visual evoked potential. Why I'm doing a visual evoked potential is to identify plaques which are smaller. Like, let us take an example here. Suppose this is optic nerve. I'll just highlight it. Suppose this is optic nerve, and the plaques which are present in the optic nerve are very, very small. Like in this case, I've shown these plaques only 0.6 millimeter, lots of them. But these plaques are multiple in the optic nerve of the patient. But you can see the problem is that they will definitely interrupt the flow of current because there are multiple plaques in the optic nerve. So when I check the voltage generated, it would be relatively lesser. So visual evoked potential showing a report of increased latency period. That's what the examiner is trying to say, slowed conduction. So increased latency period in visual evoked potential is a test that is useful for diagnosis of this patient. The third test is again very peculiar and is to be remembered, that is CSF study. You will notice that in this condition, one, the cell count is slightly increased, mild to moderate pleocytosis. Here I'll just say a number, I'm not writing it. Cell count more than 75 cells per normal cells in CSF are 0 to 4 lymphocytes, 0 to 4, 5 lymphocytes. But if the cells are more than 75, then it is unlikely to be multiple sclerosis. Similarly, proteins can be slightly increased, but if they're grossly increased, then it is unlikely to be multiple sclerosis. So cells more than 75 and proteins more than 100 milligram per deciliter is unlikely to be multiple sclerosis. Here you will have mild to moderate pleocytosis with slight increase in proteins. Now that's a very non-specific term. So how to knock sense into it? They have said that we'll be doing a test in this patient, which is that the CSF of this patient will be subjected to electrophoresis. In no other medical disorder you will read about CSF electrophoresis except for multiple sclerosis. And when you do this test, the report will say the following terms, which is like a straight pickup point for multiple sclerosis: oligoclonal. That's because, why oligoclonal? Because the target, I remember I told you, was MOG, myelin oligodendrocyte glycoprotein. So CSF electrophoresis basically represents the antibodies that are produced by the B cells which are attacking MOG, that is myelin oligodendrocyte glycoprotein. So these oligoclonal bands in the CSF will be obtained in the patient. And if you read this in any question, you know that you are dealing with a question of multiple sclerosis. So let's just revise the McDonald's criteria here. He says that if you are having two symptoms which are separated by at least 4 weeks, symptoms should be more than 24 hours apart to rule out TIA, and any of these are turning out to be positive. What I mean by any of these turning positive is that ideally it should be a gadolinium enhanced MRI. That is the imaging modality of choice for this condition. However, if the plaques are small, you can go in for visual evert potential, and the backup is CSF study in a patient that will be revealing presence of oligodendrocytes targeting antibodies which are intrinsic to the CNS of the patient. Remember, the T cells came from outside, but the B cells were the one of the spinal cord, of the brain and the spinal cord, and they're attacking the self targets of oligodendrocyte. The main function of oligodendrocyte is to provide the insulation over the axon, and the insulation is gone. Well, then the repair system comes in. The repair will cause gliosis and plaque formation in this condition. So once we get the diagnosis right for this patient, now is the time for treatment. So we will now study regarding drugs which are useful for treatment of multiple sclerosis. Coming to treatment of patients of multiple sclerosis, if he specifies the word acute attack or acute deterioration in a patient, then the first line answer is methylprednisolone. If person is not responding even to methylprednisolone, we might be using plasmapheresis, but first line approach is always steroids, and now my objective is to prevent such things from happening. So we will study regarding disease modifying drugs for multiple sclerosis. The first we shall be using is beta interferon injections, which will be given either on a weekly basis, or if we can give it like thrice a week. Route of administration can vary. Intramuscular is usually once a week, and subcutaneous is 3 times per week. And there are subtypes also like beta interferon 1A, 1B. The second drug, which is immunomodulatory and is again given in form of injections, is glatiramer. This is formed up of 4 amino acids, and it is the name of the amino acids that you need to remember, which would be glutamic acid. Then would be lysine, alanine, and tyrosine. What I'm doing here is that I'm providing to this patient the raw material for myelin basic protein, and the immunomodulatory action is like a bonus here, which will prevent the further deterioration of the patient. The disadvantage of these two drugs is parenteral administration, and patients hate injections. So what I can do apart from this is, once they stabilize, I can start them on oral molecules. There are 2 oral molecules available which can be taken once a day. One is oral fingolimod. The second is DMF, that is dimethyl fumarate. Dimethyl fumarate is even used in psoriasis. So you would have read about this DMF earlier also. These drugs have moderate efficacy. I will talk about those who have high efficacy, but high efficacy does not mean that it becomes the drug of choice, because they could be side effects also. So we are more comfortable using moderate efficacy drugs, and we would be having less side effects of these drugs also. The treatment that we're discussing at the moment is treatment for the relapsing variety of multiple sclerosis, where the symptoms would come, peak, then stabilize, then go down, because the disease has a waxing and a waning course. So symptoms may not be persistent for entire month. They might be like for 10 days a month, 15 days a month. When person has appreciable muscle cramps or spasticity, then the symptoms would gradually reduce. And with drugs, obviously the symptom profile of the person will become relatively lesser. The objective of treatment is mainly to convert this patient from going into secondary progressive multiple sclerosis, because that has a downhill course. With the current treatments that we have been successfully able to reduce the conversion of relapsing multiple sclerosis into secondary progressive. The percentage of conversion with these drugs is only 1%. So this disease may not affect the total, I would say, the quanta of life. Like if life expectancy in India is 65 years, a multiple sclerosis patient might live for 65 years. But the quality of life gets hampered, because if you can't walk, you can't communicate, you can't drink water, you are always having this pain due to trigeminal neuralgia, that affects quality of life. So this disease contributes to mainly morbidity as compared to mortality. Now we have very highly efficacious drugs for management of this condition also, by the name of natalizumab, which is given as once a month infusion. The main function of natalizumab is that it will inhibit the binding of the T lymphocytes to the capillaries related to the blood-brain barrier. And once you inhibit the binding of the T lymphocytes, then the damage to the blood-brain barrier is minimized. And apart from that, the neurological deterioration also gets primarily minimized. There's a disadvantage to this drug, and that is the reason that point number 5 is of special interest to our examiners. There is a virus by the name of JC virus that you have read multiple times. It is called as John Cunningham virus. One, you should know the full form here, John Cunningham virus. The surprising thing is that this virus lives in symbiotic relationship with our body. It is regularly shed in urine of normal people. Like, it's a possibility that normal people like you and me might be having this virus in our body. It is shed in the urine regularly. We are exposed to this, but it is not causing any problems. It's living in the body, but it's not causing any problems. But in people who are on natalizumab, because it will downgrade the immunity at the same time, this virus can actually then cross the blood-brain barrier and can contribute to development of a disease called as PMF. That is called as progressive multifocal leukoencephalopathy. This can cause even worsening of the neurological features of the patient. Like, already this patient is bedridden, person can't talk. You have given this infusion and the person will deteriorate even further. Though the incidence of this side effect is relatively less, but still, because of this side effect, the Federal Drug Authority has not mentioned this drug in the starting of the textbook, or has not mentioned it in the starting of the treatment algorithm, but has mentioned it as a backup, that these monthly infusions can be used subsequently if the person is having a poor response or is progressing in spite of the drugs that are mentioned superiorly, that is the parenteral drug glatiramer and beta interferon, and oral drugs fingolimod and DMF. Natalizumab is ideally recommended for patients who are JC virus negative, because we can check for antibodies. If a person is already having antibodies to JC virus, the deterioration is even faster with respect to PML. So the guidelines at the moment is only JC virus negative patients are eligible to receive infusions of natalizumab, and it will prevent the further deterioration of the patient. So because of the side effect, we were always looking at an alternative molecule that could be available, which we have now, and is by the name of ocrelizumab. This molecule basically acts by attacking B cells. Remember, in multiple sclerosis, there are T cell and B cell impact. The B cell impact was the one which was endogenous to the CNS and was producing antibodies against the oligodendrocytes. It was producing antibodies against MOG, the myelin oligodendrocyte glycoprotein. So this will handle those B cells, and the mature B cells are the ones which will only be attacked. That is the ones which express CD20. You can remember one more drug that attacks CD20 and is used in non-Hodgkin's lymphoma, that is rituximab. So ocrelizumab and rituximab attack CD20. Now, what is the advantage of doing this job of attacking only CD20 is because these are the main cells which are causing damage, not the immature B cells and neither the plasma cells which produce antibodies. So it is selective targeting. I don't want to harm the young B cells. They are not causing any problem for me. I don't want to harm the plasma cells because they're producing antibodies for me. But the mature B cells expressing CD20 are the problematic cells in this condition. So we are doing selective targeting in these patients, that we will deplete the mature B cells expressing CD20 antigen only. Ocrelizumab has been now approved by FDA for management of primary progressive multiple sclerosis. Remember, I told you that the most severe variety of multiple sclerosis is PPMS. Till last year, you would have noticed that in the lectures I was saying that there is no treatment for PPMS, but currently, according to the current update of Harrison, it is mentioned that ocrelizumab now is allowed for management of primary progressive multiple sclerosis. This is a condition in which, like, first neurological symptom, optic neuritis, spasticity, urinary incontinence, then trigeminal neuralgia, glossopharyngeal neuralgia, bedridden state, one after the other. This is like every month a new neurological symptom for the patient, and he's become, in 6 months, person has become bedridden or even faster. So there is a gradual, because over months, deterioration of the patient, and we never could do anything for it, because RMS we still was able to manage, but for PPMS prognosis was bad. But now we are having ocrelizumab that is selective targeting, so results are relatively better. I would now like to cater to a fact which is wrongly given in some pharmacological informations or pharmacological MCQs, where they mentioned that mitoxantrone is the best drug for or the most effective drug for management of multiple sclerosis. That's wrong, because Harrison has categorically mentioned that mitoxantrone, due to its cardiotoxicity, is not recommended for current management. It is highly efficacious. He's included it in the list of highly efficacious. So you might send me a snapshot saying, okay sir, it is written highly efficacious. He is written categorically highly efficacious for treatment, but the side effect also has to be considered. And if you will read that paragraph for mitoxantrone, the last line is, it is not currently recommended for management of multiple multiple sclerosis. So if they ask you to compare between natalizumab and mitoxantrone, do not answer mitoxantrone, because I just told you the cardiotoxicity component. It is natalizumab which is recommended, superior to mitoxantrone. Natalizumab has a side effect of progressive multifocal leukoencephalopathy that can be minimized by giving it only to JC virus negative patients. And ocrelizumab can also be used in place of natalizumab, and it is also recommended for primary progressive multiple sclerosis. So that's the pharmacological aspects that I want you to remember for this topic. This is a very straightforward topic. The names might sound a little jazzy to you, but this is one of the easiest topics to solve, or the questions of these are one of the easiest ones to solve when it comes to neurology, because the manifestations are so many that you can correlate. So for questions here, it is unlikely that he will give you all except questions. You see, there's so many, no? So therefore, it's unlikely he will say all except. It would be straightforward. He'll give you a clinical case, young female, Caucasian background, North American background, having problems with vision, having problems with talking, speaking, drinking, becoming bedridden, gait abnormalities in a patient, symptoms increasing on heat exposure. I mean, what can be easier than that? No, heat exposure causing worsening of neurological symptoms. That is Uttha phenomenon. I mean, the question is like crying out loud. Okay, I am multiple sclerosis. All you need to answer is MS, or maybe answer imaging modality or oligoclonal CSF bands for this condition, or talk about the pharmacological aspects for this. So thank you for listening, and keep working, guys. Knowledge is power, as I've said multiple times. I'm repeating that again. The more you listen, the more you learn, the more wiser you are, the more wiser decisions you can take in this clinical based paper. Thank you so much for your patience and hearing me out.